In this second lecture on cardiomyopathy, we're going to talk about hypertrophic cardiomyopathy, predominantly in cats, and other feline myocardial diseases. The pathologic features of hypertrophic cardiomyopathy can be variable, and you may see concentric or asymmetric left ventricular hypertrophy. This would be manifest as either thickening of the left ventricular free wall or the interventricular septum, or both. The left ventricular internal cavity can be smaller than normal, especially at the end of systole. Papillary muscle hypertrophy can be an early finding. And on histopath, we may see evidence of myofiber disarray and/or fibrous tissue deposition in the myocardium. Another possible finding is arteriosclerosis of the small coronary arteries within the myocardium. As a result of left ventricular hypertrophy, the left atrium may become enlarged, and the right heart may also become hypertrophy or enlarged. The hypertrophy leads to a reduced cavity size and/or a stiff left ventricle, and classically, diastolic filling is thought to be compromised with hypertrophic cardiomyopathy. Since most of the coronary flow happens during diastole, periods of tachycardia will shorten the duration of diastole and may further limit myocardial blood flow to the hypertrophied myocardium. Thus, in some cats, it's thought that the myocardium might get stiffer following tachycardia, and this is part of the rationale for potentially using beta blockers. Reduced compliance of the left ventricle leads to left atrial enlargement, and myocardial hypoxia or ischemia can also lead to cardiac arrhythmias. We do see hypertrophic cardiomyopathy in dogs, but it's very uncommon. It's only been reported in a handful of cases, and it may be more common than normal in German short-haired pointers, German shepherds, and maybe the Shih Tzu. Affected animals can develop congestive heart failure or cardiac arrhythmias, although sudden death may be the first sign of disease in dogs. Hypertrophic cardiomyopathy is the most common cardiovascular disease in cats, and it's the most common cause of congestive heart failure, arterial embolism, and sudden death. And it may be that cats with hypertrophic cardiomyopathy are more likely to have an unexpected death under anesthesia. If we consider the pathophysiology here, we have the right atrium and right ventricle in blue, the left atrium and left ventricle in red, and the blood pressure in the aorta is perhaps 120 over 80 millimeters of mercury. Blood pressure in the left ventricle in a normal situation is maybe 120 over 5 in diastole. Left atrial pressure has to be just a little bit higher than left ventricular diastolic pressure in order to fill it, so we'll call that 6. And the pressure in the pulmonary vein and pulmonary capillary might be 7 millimeters of mercury. So that would be our normal setting. And if we take a cat and give it hypertrophic cardiomyopathy, and perhaps also a contributor of tachycardia, now what happens is the diastolic pressure in the left ventricle rises to perhaps 25 millimeters of mercury. So the left atrial pressure has to rise if it's going to fill the left ventricle in diastole. So we'll call that 26 millimeters of mercury. And that pressure is transmitted back to the pulmonary veins and the pulmonary capillaries. We'll call that 27 milliliters of mercury, which is going to cause fluid to ooze from the pulmonary capillaries, and that's going to create pulmonary edema. So that's the pathophysiology that's behind hypertrophic cardiomyopathy when congestive heart failure develops. This is an example of a cat that got tachycardia-induced congestive heart failure, 6-year-old cat that was asymptomatic with a previously noted 2 out of 6 systolic murmur. It had a laceration and required anesthesia for sutures, and 2 days later the cat presented with respiratory distress, and on thoracic radiographs there's pulmonary edema. Differential diagnoses for hypertrophy of the left ventricle in cats, besides hypertrophic cardiomyopathy, can be systemic hypertension, which we might call hypertensive heart disease. Aortic stenosis is a congenital disorder. Hyperthyroidism can also cause hypertrophy of the cat, and other myocardial diseases. So these differential diagnoses are listed here. If we just think about differentials for cardiac murmurs in cats, cardiomyopathy, any form of cardiomyopathy can cause a murmur. Another benign cause of murmur is dynamic right ventricular outflow tract obstruction, which can be seen in some cats, especially cats when they're excited. It creates a murmur, but it doesn't result in any pathology that would be of any consequence to the cat. Some cats with hypertension can have a murmur, as can cats with hyperthyroidism. Anemia can also lead to a murmur, and congenital heart disease can lead to a murmur. So what causes hypertrophic cardiomyopathy in the cat? It's thought that probably many cats have abnormal mutations of the sarcomeric proteins, like actin, myosin, troponin, beta-myosin heavy chain. And in people, many abnormalities have been identified to cause hypertrophic cardiomyopathy. We have only a few identified in cats, mutations of myosin binding protein C in Maine Coon cats and ragdoll cats. There is some suspicion that the environment may play a role and that large or overweight cats may be more likely to get hypertrophic cardiomyopathy. Cats with hypertrophic cardiomyopathy may present with congestive heart failure, as is this cat that died as a result of pulmonary edema, or arterial thromboembolism, or syncope, or sudden death. Virtually any breed can get hypertrophic cardiomyopathy, although there is a predisposition in certain breeds, and it can happen at any age. For the development of congestive heart failure or arterial embolism, male cats seem to be predisposed over female cats. Many cats that present with heart failure or a clot have a prior history of a murmur or a gallop, and cough is typically absent from cats that have heart failure unless they have pleural effusion. So cats with cough should be thought to be more likely to have asthma or heartworm disease or a lung tumor or some other problem. Cats with congestive heart failure may present with dyspnea or open mouth breathing. They're often lethargic or hiding or anorexic for several days before presentation. They may present for a collapsing episode like a seizure, but in most cases that's syncope, perhaps due to outflow tract obstruction. And they may present for limb weakness or sudden onset paralysis with arterial embolism. A recent stressor such as anesthesia or fluid administration or corticosteroid administration may also trigger the development of congestive heart failure. This is a large retrospective study performed by Fox and colleagues, and maybe one or two notable things from this. This is the incidence of hypertrophic cardiomyopathy, and you'll see that it happened at just about any age. And if we look at cats that have either hypertrophic obstructive cardiomyopathy or hypertrophic cardiomyopathy, the majority of them are domestic short hair cats. So while there is a predisposition, domestic short hair or domestic long hair cats clearly are going to form the majority of the cats we see with cardiomyopathy. This table from the same paper looks at either cats that are healthy, have a normal echocardiogram, or cats with hypertrophic cardiomyopathy, and they're separated out here as either HCM without obstruction or HCM with obstruction, hypertrophic obstructive cardiomyopathy, HOCM. And we're interested in the murmur grades, so we have murmur grades here from 1 to 5. And I think you can see that the cats with cardiomyopathy, many of them had murmurs in the 1, 2, or 3 out of 6 range. But there are a proportion of cats with hypertrophic cardiomyopathy that don't have any murmur. In this case, 30% of the cats with hypertrophic cardiomyopathy did not have a murmur. So on physical exam, we might identify a cardiac murmur. That murmur is usually easiest to hear at the sternal border, just to the left or right of the sternal border. A cardiac gallop may also be present, classically an S4 gallop, due to the atria contracting into a stiff ventricle, and that might be heard best with the bell of the stethoscope. Cardiac arrhythmias may be noted, and cats with heart failure may present with pulmonary edema and crackles, or pleural effusion with lung sounds that are dull ventrally. If the jugular vein is distended, it's more likely that the cat has pleural effusion. They may have weak arterial pulses, abnormal mucous membrane color, delayed capillary refill time, and cats with congestive heart failure or arterial embolism may be hypothermic. And the heart rate and temperature are somewhat linked. In cats that have a low body temperature, the heart rate is often a little slower. It seems to affect the sinus node firing rate. And certainly cats may present with signs of arterial embolism, lack of pulses and firm gastrocnemius muscles and cool dark nail beds. Here's a cat on the left-hand side that has jugular vein distension and pulsation as a result of cardiomyopathy. And on the right-hand side, we see another cat that has, we'll look right here in the jugular furrow and look to see it. You can see the jugular vein pulsating at least halfway up the neck in this particular cat. And again, the hairs accentuate it. You don't have to trim the hairs on the neck in order to see the jugular vein distension. So cats may have a murmur. I don't have a We have a cat on our dog picture because I don't have a picture of that. The murmur is usually loudest right at the left sternal border or the right sternal border. And then cats can have either a murmur or they can have a gallop. It's usually thought to be an S4 gallop, happening as a result of the atrial kick into the stiff ventricle. We'll listen here for the gallop, which comes and goes on this recording. Electrocardiographic findings can include ventricular premature depolarizations or ventricular premature contractions, ventricular tachycardia, or atrial fibrillation. Thoracic radiographs are indicated to identify cardiomegaly, to determine whether congestive heart failure is present or not, and to identify other thoracic diseases. In this cat, again, there's a lung tumor. So we're trying to find other potential causes for arterial thromboembolism in this case. So two lateral thoracic radiographs from a normal cat on the left and a cat with hypertrophic cardiomyopathy on the right. Again, there's cardiomegaly, which can be identified on the lateral radiograph, and if you measure the vertebral heart size, it's often less than 8.1 vertebra in a normal cat. The cardiac enlargement may be easier to identify on the dorsal ventral or ventral dorsal view, where you may see evidence of biatrial enlargement or a Valentine-shaped heart. So another thing that we can do is to try to measure the vertebral heart size for the width of the heart on the DV view. So if we take the long axis of the heart and go 90 degrees to that, and take that measurement of the width of the heart, the yellow arrow, and bring it back to the lateral thoracic radiograph. Start at the beginning of the fourth thoracic vertebra and count the number of vertebra. Normally that is less than 3.4 vertebra, and in this cat it's 5.3 vertebra. Again, another numeric way to identify cardiac enlargement in cats. Here's a cat with pulmonary edema as a result of congestive heart failure from hypertrophic cardiomyopathy. Cats sometimes will have patchy areas of pulmonary edema. They don't always have it in the classic perihilar or perihilar and caudodorsal region. And here's another cat that likely has biventricular heart failure with pulmonary edema, as well as pleural effusion with the lung lobe edges retracted, and it's hard to see the edges of the heart here, and some evidence of hepatomegaly as well. This is a cat with chronic pleural effusion, and on the left-hand side you can see that the lungs are hardly inflated at all. And on the right-hand side, the same cat after thoracentesis and after removing the fluid from the chest, there's significant re-expansion of the lungs. Pointing out that it's particularly helpful to tap fluid from the pleural space in cats that are dyspneic. Echocardiography is the key diagnostic test for identifying hypertrophic cardiomyopathy in cats. And one of the key measures is the thickness of the interventricular septum and the left ventricular free wall. And in most cats, those measures will be greater than 0.55 to 0.6 centimeters in diastole. We'll also look for evidence of left atrial enlargement, especially in cats who have left-sided heart failure or have arterial embolism. We'll look at the papillary muscles to see if they're hypertrophied. And there may be right-sided heart enlargement or pulmonary artery enlargement as well. There's a normal cat in the upper left-hand corner to get an idea for contractile function, wall thickness, and cavity size in a normal cat. The cat on the upper right-hand panel has hypertrophic cardiomyopathy with thickening of the interventricular septum and left ventricular free wall. And the cat on the bottom panel has prominent papillary muscles with hypertrophy and a small left ventricular end systolic cavity size. So again, one of the things we're going to measure here is the interventricular septum and the left ventricular free wall. And the interventricular septum and left ventricular free wall in diastole are typically thicker than 0.55 to 0.6 centimeters. This is a cat with asymmetric hypertrophy. The hypertrophy can be concentric like the previous picture, or it can be asymmetric with mostly hypertrophy of the left ventricular free wall. Another thing we're interested in is the size of the left atrium. And as a general rule of thumb, we can measure the left atrium a number of ways, or we can kind of just eyeball the left atrial size. And so there's the aorta on this pathology specimen, and this is all left atrium with the left auricular appendage wrapping around there. And that's very similar to what we're going to see here with the aorta on the echocardiogram and left atrial enlargement with the left auricular appendage. Mild left atrial enlargement in this case. How do we know that? Well, if we take an eyeball size of the aorta and say, well, it's about as big as that white circle. The question is, how many of those white circles fit inside of the left atrium? And in a normal left atrium, you can fit 2.5, maybe 3 aortic dimensions inside a normal left atrium. So this cat has a markedly enlarged left atrium compared to the size of the aorta. This would be a cat who's at increased risk for arterial embolism and who very well might have had congestive heart failure. Here's another cat with marked left atrial enlargement, and you can see the spontaneous contrast filling into the left atrium. That spontaneous contrast is a marker of a cat at increased risk for thrombus formation. On echocardiography, there's a few things we might measure on M mode as well. And we might be interested in other echocardiographic findings. We may look for systolic anterior motion of the mitral valve, left ventricular outflow tract velocity to measure the pressure drop across the outflow tract. We might look at diastolic function through a variety of other mechanisms as well. So if we think about this, and this hypertrophy present right here in the interventricular septum in this particular cartoon diagram, and we think about the pressures. Well, the blood pressure in systole in the aorta might be 120, and the blood pressure in the left ventricle might be 150. There's a drop in this case across the outflow tract because of the hypertrophy, it creates essentially a form of obstruction to the LV outflow tract, and that will cause turbulent blood flow as it's pumped out into the aorta, and that may pull the mitral valve towards the septum in systole, so systolic anterior motion of the mitral valve, and that will create a jet of mitral regurgitation. So on this echo with the same orientation, we can see turbulence in the aortic outflow tract as well as evidence of mitral regurgitation. And it's generally thought that in cats that have LV outflow tract obstruction, you should try to avoid giving positive inotropes. If you give a positive inotrope and you increase the vigor of contraction, you might worsen the obstruction to the outflow tract, which might raise the pressure in the left ventricle and cause it to work even harder, or potentially might even result in hypotension. So many people have advocated that you should use caution with use of positive inotropes in cats with clear-cut left ventricular outflow tract obstruction. It's another cat with left ventricular outflow tract obstruction, and we can see turbulence in the aorta and secondary mitral regurgitation. Mitral inflow patterns and tissue Doppler may be helpful to try to characterize whether diastolic dysfunction is present or not. Diastolic dysfunction is often present in cats with hypertrophic cardiomyopathy. There's a link here to get to a training video for veterinarians who might be interested in trying to learn some of the basics of echocardiography. Blood pressure is often measured in cats who have left ventricular hypertrophy to try to exclude systemic hypertension as a cause for the left ventricular hypertrophy. We would usually use the Doppler technique, but others use an oscillometric, and I think the key is to establish normal values in a fashion, whether you measure it on a limb or the tail in your own environment. Most cats who feel well have a blood pressure that's at least 120 millimeters of mercury in systole, and the veterinary profession has identified that cats with a systolic blood pressure less than 90 millimeters of mercury might be identified to have hypotension. I think there are a lot of cats who have a blood pressure of 100 or 110 who might not actually feel that well on medications. And then if we were considering hypertension, you'd like to get multiple measurements at multiple sessions, and consistently for our place, we usually are interested if the blood pressure is consistently above 160 or 170 millimeters of mercury. Laboratory testing may be useful to try to characterize the heart disease and to determine whether there's any concurrent systemic disease. In most cats with heart failure, the complete blood count is normal, or there may be a mild elevation in white cell count. The chemistry profile is often perfectly normal except for cases of advanced disease or after diuretic administration. We may see azotemia, we might see increased liver enzymes, and diuretics may lead to electrolyte depletion. Thyroid testing to search for hyperthyroidism is recommended in cats over 6 years of age. And NT-proBNP concentrations are abnormal in the majority of cats with congestive heart failure. They're also abnormal in a number of cats who have asymptomatic or occult hypertrophic cardiomyopathy. These pictures from Dr. Fox identify BNP levels for healthy cats, cats with occult cardiomyopathy, and cats with congestive heart failure. So BNP concentrations are often elevated when there's hypertrophic cardiomyopathy and there's progressive elevation with worsening heart disease. So maybe two situations where you could think about using an NT-proBNP test. One would be in an asymptomatic cat where you've noted murmur or gallop arrhythmia and you're trying to decide, should I do an echo? And some people would just say, yes, do the echo. And other people would like an extra little piece of information to help them counsel the owner on whether they should spend money on an echo. And so most cats who do not have significant heart disease have a BNP that's going to be less than 100 picomole per liter. The second clinical situation would be cats that have respiratory signs or respiratory distress, such as dyspnea, cough, or open mouth breathing. And you're trying to answer the question, is it heart disease or is it lung disease? And if the NT-proBNP is greater than 256 picomole per liter, it indicates a high chance that the signs of respiratory distress are due to congestive heart failure. So what drugs might we use? Some people propose that it's useful to give drugs to either slow the heart rate or improve diastolic function or reduce left ventricular outflow tract obstruction. And beta blockers are probably the drugs that are most commonly used, although some people use calcium channel blockers as well. People might be more likely to give a beta blocker to a cat with hypertrophic cardiomyopathy if it was particularly tachycardic to try to keep the heart rate slow, or if they had ventricular arrhythmias, since beta blockers might reduce the frequency of arrhythmias. If they have outflow tract obstruction or systolic anterior motion of the mitral valve, then beta blockers might reduce that obstruction and reduce the amount of mitral regurgitation. Cats that are concurrently hyperthyroid may benefit from beta blockers, as beta blockers may blunt the effects of high thyroid values on the heart. In cats that have congestive heart failure already, one study indicated there was a worse outcome if beta blockers were initiated after development of congestive heart failure, so we are less likely to give a beta blocker if congestive heart failure has already developed. And again, if it's used in the asymptomatic setting, the question is, will it alter disease progression? And one 5-year study failed to document a clear-cut benefit of atenolol in the asymptomatic cat population. So the clinical scenarios, we see cats who present with dyspnea and congestive heart failure. We see cats presenting with arterial embolism. Perhaps the least common scenario is syncope or sudden death. And we see cats that have a murmur or gallop who are asymptomatic. They essentially have occult heart disease. For cats that have congestive heart failure, they would usually get furosemide. They might be treated with an ACE inhibitor. If they have outflow tract obstruction, some people might use a beta blocker. We're less likely to do that. And some people would use pimobendan. I think we are likely to do that if there is no left ventricular outflow tract obstruction. But if there is outflow tract obstruction, we usually would not start pimobendan at that stage. In cats that have congestive heart failure, they usually have a left atrium that's pretty big, and we would usually start an antithrombotic like clopidogrel. And dietary modification may be indicated as well. So arterial embolism occurs in 10 to 40% of all cats with cardiomyopathy. They typically originate in the left atrium or left ventricle. They're less likely to originate in the right heart, in which case they cause pulmonary embolism. And an increasing left atrial size is associated with the development of arterial thromboembolism. Here you can see that the paw pad is pinker on the unaffected limb compared to the affected limb. And this is a thrombus removed from the terminal aorta of the cat. So sites of embolism, the rear limbs are most frequently affected, 85 or 90% of the time. It's much less often they'd go to a front limb, although it's possible to go to other places like the brain or the myocardium. And this is an example of pulmonary embolism in a cat that had right heart disease. We don't usually see the clot bouncing in the left atrium, but when we do, it's a visually impressive finding. So this is a cat with moderate to marked left atrial enlargement and a large thrombus in the left atrium. We're more likely to see thrombus in the left auricular appendage. So this is the left auricular appendage here. That's where they tend to originate, and there's a large thrombus in this cat's atrium. So there are two situations. The first might be treatment of active arterial embolism, for which it's a little hard to know what's the best approach to therapy: supportive care, analgesics, a little bit of gentle warming, antithrombotics. We would usually give a high dose of heparin and or a loading dose of clopidogrel. Thrombolytics have been evaluated, but they've not shown to be associated with a better outcome. And surgical or catheter embolectomy is also possible, but is uncommonly used. The other situation we would be thinking about is prevention of clot formation, either after a clot is formed and or in a cat who we identify has an enlarged left atrium and is at risk for thrombus formation. And there are a variety of choices there. Of these, currently probably clopidogrel is most frequently used, although others might use a combination of clopidogrel with aspirin or low molecular weight heparin or newer drugs like rivaroxaban or apixaban. We no longer use Coumadin due to difficulty in titrating the drug. So one could ask the question, should I treat the asymptomatic cat? And one question would be, what's the goal of therapy? Presumably the goal is to delay the time until the cat develops heart failure or arterial embolism or sudden death. And some people use surrogate endpoints to try to propose that might happen. They might like the heart rate to be slower. They might like to alleviate the outflow tract obstruction or make systolic anterior motion go away. They might like to see some change in Doppler indices and or troponin that drops a little bit. But for the most part, longitudinal studies are lacking, and we're not sure which medication might be associated with a delay in the time until heart failure or arterial embolism develops. In general, the bigger the left atrium is, the more we might be inclined to start an antithrombotic. And I think we might be a little hesitant to start an antithrombotic if we knew it was a cat that needed anesthesia or surgery. So how long will cats with hypertrophic cardiomyopathy live? So the prognosis is linked to the presenting signs, and asymptomatic cats probably will live on average at least a couple years and perhaps even longer than that. Cats with congestive heart failure, depending on how dedicated their owners are, might live for a significantly shorter period of time. Various studies have shown anywhere between 92 and 563 days, or even shorter than that in a recent study, as we'll see coming up here. And cats with arterial embolism, probably at least half of them are euthanized at the time of arterial embolism due to concerns about a poor prognosis. But cats that are not euthanized might live somewhere between 60 days and a year's period of time. And there have been a couple other things that might be associated with the prognosis, including atrial size, age of the cat, and their fractional shortening. Cats with left ventricular outflow tract actually might have a slightly better outcome. So this takes us back to that large retrospective study of asymptomatic cats from Dr. Fox. And so if we look at the cats who were healthy and compare them to the cats with hypertrophic cardiomyopathy, the healthy cats had a pretty low likelihood of getting cardiovascular death, whereas about 28% of the cats with cardiomyopathy died as a result of heart disease. So if we look at just the cats with either hypertrophic obstructive cardiomyopathy or hypertrophic cardiomyopathy, the time to heart failure in these cats was quite a long period of time, a number of years till they developed heart failure, and again, a number of years until arterial embolism developed in these cats. And if we compare the healthy cats in the blue line to the cats with cardiomyopathy, and we look at the survival time in years along the bottom and the percent survival, we see that the healthy cats in blue lived quite a significant chunk of time, and that was longer than the cats that had cardiomyopathy. So the presence of cardiomyopathy has a pretty good chance of shortening survival time in cats. If we look at the time from the onset of congestive heart failure until death, a lot of the cats were euthanized or died very early after the diagnosis of congestive heart failure. So this survival time is, on balance, quite short for these cats, although you can see that some of the cats lived a very long time after the development of heart failure. And if we look at the time from the development of arterial embolism to death, again, many of the cats are euthanized very early in the disease when they present with arterial embolism, but a handful of them will live a number of years until they either develop another clot or heart failure or sudden death. So this brings up the question of who should be screened for hypertrophic cardiomyopathy, because if they have heart disease, and if they get congestive heart failure or arterial embolism, it might be a particularly bad scenario. So one could argue that all cats with a murmur or gallop should be screened for hypertrophic cardiomyopathy, or cats with an arrhythmia. Certainly cats with open mouth breathing or unexplained respiratory distress might be candidates for screening. Sometimes hypertrophic cardiomyopathy runs in families or households of cats, so a related cat that has cardiac disease is a good cat to potentially screen for heart disease. And some people who own breeds predisposed to cardiomyopathy, like Maine Coon cats or Norwegian forest cats or ragdoll cats, might elect to screen their cat for cardiomyopathy as well. So we talked about hypertrophic cardiomyopathy. There's a number of other less common forms of heart disease in cats. We'll talk about just a few of those for a minute. If we talk about the frequency of heart disease in our clinic, we see a lot of hypertrophic cardiomyopathy. We see a number of cats that have systemic hypertension. We see some cats with unspecified cardiomyopathy. Very few cats with dilated cardiomyopathy. A number of cats that have arterial embolism who are put to sleep before they ever get an echo. And we see a relatively small chunk of cats with congenital disease. I think a lot of these cats with an unspecified cardiomyopathy started out as hypertrophic cardiomyopathy and then moved into this bin as their heart disease progressed. Restrictive cardiomyopathy is dramatic fibrosis of the left ventricular endocardium, often with a little inflammation in the myocardium below the fibrosis. This is thought to limit diastolic filling in the heart and leads to left atrial enlargement, and these cats are prone to arterial embolism. If we take a closer look at that picture, we can see here's the interventricular septum and the left ventricular free wall, and the endocardium has this white scar tissue as well as some thrombus formation associated with it. Restrictive myocardial disease may also be identified as a myocardial form, usually characterized by diastolic dysfunction in a non-hypertrophied, non-dilated ventricle. This classification may overlap with unspecified cardiomyopathy in cats. We previously talked about arrhythmogenic right ventricular cardiomyopathy in cats. It predominantly results in right heart enlargement with tricuspid regurgitation and right-sided heart failure. And then unspecified cardiomyopathy, they don't fulfill the clear criteria for dilated hypertrophic or arrhythmogenic cardiomyopathy. They'd have no obvious pericardial, coronary, or valvular disease or systemic hypertension driving the heart disease. And I think a number of these cats might have started out as hypertrophic cardiomyopathy, but as the heart myocardium gets replaced with fibrous and scar tissue in the myocytes die, they no longer fulfill the criteria for hypertrophic cardiomyopathy. Here's an example of a cat that had hypertrophic cardiomyopathy who ended up getting significant focal thinning of the left ventricular free wall. Another thing we can see in cats are abnormal or extra Chordae tendinae. They're sometimes referred to as moderator bands in the left ventricle. They can be seen in a variety of forms of cats with cardiomyopathy. If we look inside the left ventricular cavity in this cat, we see this additional webbing inside the left ventricular cavity, these abnormal chordae. And they were originally proposed to cause diastolic restriction, diastolic filling. It's a little bit unclear whether they're an innocent bystander or they're some sort of a response to other forms of cardiomyopathy. Here's a cat that has unspecified cardiomyopathy who has a moderator band right here. spanning from the papillary muscle to the interventricular septum. So again, overall laboratory testing in cats with various forms of heart disease. The complete blood count is often normal. A chemistry profile may identify azotemia, increased liver enzymes, or electrolyte abnormalities. Thyroid testing is appropriate for cats over 6 years of age. In cats with dilated cardiomyopathy or LV systolic dysfunction, measurement of taurine in plasma and whole blood may be recommended. If there's significant right heart enlargement, it may be appropriate to test for heartworm disease with an antigen and antibody test. And NT-proBNP is elevated in most cats with significant cardiac disease and gets progressively elevated as heart failure develops. Management of heart failure in cats in general. Furosemide is typically appropriate and the dose is titrated to the lowest dose possible to control signs of congestion. Pimobendan may be used unless there's left ventricular outflow tract obstruction. It's usually avoided if there is left ventricular outflow tract obstruction. Many people use ACE inhibitors in cats with congestive heart failure, and most cats with heart failure have an enlarged left atrium, and so some sort of an antithrombotic is usually appropriate. A variety of other therapies may be indicated as well.